A cost-effective method of mechanical lithotripsy for the successful endoscopic management of Bouveret syndrome. We have no disclosures. We present the case of an 88-year-old lady who presented with severe vomiting and abdominal pain. CT showed a 4 centimeter gallstone which had migrated through a bilioduodenal fistula into the duodenal bulb, causing gastric outlet obstruction. This condition is also known as Bouveret syndrome. Potential treatment options, including surgery, were discussed with the patient who preferred an endoscopic or non surgical management strategy. EGD was performed under conscious sedation and showed a large gallstone impacted in the duodenal bulb. In order for oral extraction of the stone to be successful, fragmentation is required to allow passage through potential sites of resistance, such as the pyloric ring, the gastroesophageal junction, and also the upper esophageal sphincter. Initial attempts with electrohydraulic lithotripsy with high power setting and 5 pulses per foot pedal activation proved futile and was abandoned after 2 probes were used. Possible reasons for failed EHL include a high stone density or inadequate retention of the saline medium, which is crucial for EHL in the duodenal bulb, due to leakage of saline from the pylorus and descending duodenum. We subsequently utilized mechanical lithotripsy for stone fragmentation with the use of a disposable through-the-scope lithotripter device. The large gallstone was impacted in the duodenal bulb and the gastroscope could not be advanced distally. Electrohydraulic lithotripsy, as shown here, was attempted with a high power setting and 5 pulses per foot pedal activation, but failed to fragment the stone. Varying the power setting also did not improve efficacy. EHL was abandoned after the utilization of 2 probes. Due to the stone size, we were also unable to extract the stone through the pyloric ring. Our endoscopy unit did not have the availability of laser lithotripsy or a mechanical lithotripter. As such, we improvised a method of mechanical lithotripsy using the following equipment that is available in most endoscopy units: a large disposable hot snare, a disposable through the scope lithotripter cable, a rescue lithotripter handle, and pliers. Here we demonstrate the assembly and ex vivo use of the lithotripter. The snare handle was cut and snare wire removed from the plastic sheath. The snare wire is back-loaded into the disposable lithotripter cable. The assembly is mounted onto the lithotripter handle and stone crushed as depicted. It is important to maintain traction on the snare wire as the crank handle is turned to maintain grip on the stone and prevent stone slippage. After the stone is crushed, the lever on the side of the handle is depressed to disengage the ratchet mechanism to allow release of the snare wire and reopening of the snare for reuse. The snare can fracture, however, requiring replacement, and we used a total of 5 snares for the entire procedure. The partially fragmented 4 centimeter stone in the duodenal bulb was extracted into the stomach. Here, we demonstrate further in vivo fragmentation of the stone to smaller pieces to permit safe oral retrieval. Here, we demonstrate a tip for optimal stone fragmentation. This involves wedging the stone at the tip of the endoscope while the snare closes to provide the optimal mechanical advantage. All stone fragments were successfully retrieved per oral with a rough net. We did not use any protective measures and did not encounter any adverse events. However, the use of a hood or overtube is recommended. Final inspection of the duodenal bulb revealed a possible fistula into the gallbladder. The gastroscope was advanced with ease into the descending duodenum, supportive of successful treatment of the obstruction. Minor bleeding was noted, but did not require any endoscopic treatment. Total procedural time was 130 minutes, and there were no immediate complications. The patient recovered well and was discharged 7 days after initial presentation. She remained well at 16 months of follow up. At review, she declined a repeat endoscopy and any subsequent surgical intervention. Bouveret syndrome is a rare entity with significant morbidity and mortality. Endoscopic management of Bouveret syndrome is becoming more favorable, especially in the elderly and frail patients. The aim of our case report is to demonstrate a method of effective mechanical lithotripsy using widely available, cost effective accessories instead of more costly devices such as EHL probes.